Thank you all. I'll be speaking a little bit about contracted socket. I have no financial disclosures, and I would like to acknowledge Madhulata, who is the oculist at Access Eye Clinic. Now, the indications when we actually want to work on a contracted socket is an inadequate socket which does not accommodate the processes correctly. So what are the causes of a contracted socket? They include congenital causes like anophthalmos and microphthalmos, which Dr. Raj has already discussed. There could be acquired causes like a tumor of retinoblastoma or enucleation or irradiation has been done. It has not been properly managed. Or it could be because of trauma because of conjunctival loss, or it could be because of a chemical injury, especially the alkali injuries, which are the worst ones and which are also called as the malignantly contracted sockets. This can also be a result of uncontrolled infection, or because of poor surgery where there is no implant has been placed or there has been tissue breakdown and the fornices have not been restored after surgery. Anophthalmos has already been discussed by Dr. Raj Anand. The problem is obviously of the bony orbit stunting, which you can see in the scan on the left side, and the facial asymmetry. In microphthalmos, again, we can have simple microphthalmos or complex microphthalmos. But what we would like to highlight is the orbital growth. The infant eye is about 70% of the adult size, and it grows rapidly in the first 12 months. By the age of 2 years, the face becomes 70% of the adult face. And by 5.5 years of age, the face of the child is about 90% of the adult face. And therefore, whatever intervention you want to do, you should do it early in life. What is an ideal socket? An ideal socket is one in which there is adequate superior and inferior sulcus. There are no bands or additions, and it is of a sufficient size to hold a prosthesis which is going to match the other eye. So when we have patients with congenital anophthalmos, we'd always like to go for an early intervention, and we always try to prefer non-surgical management like stem pressure conformers and graded conformers, like in this particular patient. Hydrogel implants has already been described, but again there are problems like rapid expansion of the implant, and therefore they are not preferred for expanding the socket. Sometimes we have got these orbito-palpebral cysts in which we just go ahead and aspirate the cyst, remove the contents, and then we can put a conformer inside, and finally we can put a custom-made artificial implant. When we deal with the actual contracted socket that we see where there is no implant, or a patient has been operated early in life and nothing much has been done, and the patient comes later in life at a much older age, beyond the 20s, and they have got this contracted socket and they want something which will make them look good, and they want some process which will match the other eye, then this is the correction sequence that we need to follow. The first thing we need to tackle is the orbital volume, and then we look at the superior sulcus and the lid laxity. We also look at the surface deficit, if any, and finally we need to correct the lid, that is the ptosis. Now the classification of contracted sockets, grade 0 is a normal socket where we can directly put an artificial eye. If there is absence of the lower fornix, we can just go ahead and do a fornix formation suture. If there is absence of the upper fornix and the lower fornix, we can do a mucous membrane graft and a fornix formation suture. If there is absence of both medial, lateral, superior and inferior fornices, one can go ahead and put a dermis fat graft and a fornix formation suture. If there is a shrinkage of the socket, especially in the case of a child, we can go ahead with a dermis fat graft, and in inoperable sockets we can put a spectacle prosthesis. So if there is a minor contracture and there are small bands, we release the bands. We can do a Z-plasty if you have got a vertical band, and if there is eyelid involvement, we can always put a nasal septal cartilage along with the mucosa. Stem pressure conformers can be tried even in the older age group, and it will help for the soft tissue contracture. It will not help with the bony contracture. So once you put these stem pressure conformers, leave it in place for a couple of weeks, and then we can remove it and put an artificial eye. If we have inadequate lid length, then what we can do is we can do a lid switch flap. We take a small flap from the upper lid and just rotate it and put it back over the lower lid. So this lid switch flap will increase the surface area of the inferior fornix, and therefore it will help in accommodating a prosthesis. So if you've got a surface deficit which is mild, we can just go ahead and do the fornix formation sutures, which you can see here. These sutures pass through the periosteum and are secured over bolsters on the skin, and here we are using 4-0 silk because silk itself will induce inflammation. If there is severe surface deficit, then one should go ahead and do a mucous membrane graft.